Okay, let's talk about the neuroblastic tumors. Now, this is actually the neuroendocrine tumor that arises from neural crest elements of the sympathetic nervous system. Main regions where you would find this neuroblastic tumors are the sympathetic ganglia and your adrenal medulla, because both of these components are actually arise from neural crest cells. Okay, now what are some of the characteristics of these neuroblastic tumors? They actually have spontaneous or therapy-induced differentiation of primitive neuroblasts into the mature elements. Then there's spontaneous tumor regression you would find in neuroblastic tumors, and there's wide range of clinical behavior and prognosis, and this wide range actually depends on the extent of histological differentiation. Now, if anyone asks you name the tumor that actually can go back from malignancy to the benign form, well, there you go. The neoplastic tumor is actually one of such tumor because it has that spontaneous tumor regression ability. That's why even if this neoplastic tumor is malignant, it can go back to the benign form. There are actually three types of neuroblastic tumors that we're going to discuss. There's neuroblastoma, there is, and there are two more which we're going to discuss later on. The neuroblastoma is actually the most common of all three, and this is the most common extracranial solid tumor of childhood. And yeah, they're actually most frequently diagnosed tumor of infancy. So yes, do kind of remember this, that this is actually the most frequently diagnosed tumor of infancy. The prevalence of neuroblastoma, which is one of the kind of the neoplastic tumor, is actually 1 in 7,000 live births, and 700 cases are diagnosed each year in the States. And the median age at diagnosis is 18 months approximately, and about 40% of the cases are diagnosed in infancy. And most of the neuroblastomas, they occur sporadically, but about 1% to 2% are familial. Now, what do you mean by the term sporadically or familial? Well, if you don't know, I'm not gonna tell you. Just pause the video and go and search on Google what is sporadic or what is familial, and anything. Anyway, now what does molecular genetics actually tell us about the neuroblastoma? The molecular genetics tell us that there's germline mutations in the gene which is called ALK gene, which is anaplastic lymphoma kinase gene, and this is a major cause of familial predisposition to neuroblastoma in a subset of familial patients. So in case of familial patients, you have germline mutations in ALK gene, while in cases of sporadic neuroblastomas, you have somatic gain of function of ALK mutations. Okay, so there's a little bit of difference. Here you can actually see in figure 1025, there's adrenal neuroblastoma in a 6-month-old child, and you can see the very large hemorrhagic partially encapsulated tumor, and this has displaced the left kidney. Okay, so yeah, this is quite a big adrenal gland for a 6-month-old child. And let's talk about the prognosis. Well, for a very high risk subset patients, there's actually a 5-year survival in the range of 40%. So yeah, not a very good prognosis, but it is actually reserved for a high risk subset of patients. And this is very important, that children younger than 18 months of age, they tend to have a significant better prognosis than older individuals. So yeah, now you can see in this figure that this is actually the adrenal neuroblastoma, and this actually composed of small cells which is embedded in a finely fibrillar matrix. We're going to talk about this histology in detail, but let's talk about the morphological features. Okay. And what is the location? Well, these 40% of neuroblastomas, they actually arise in the adrenal medulla. The rest actually arise along the sympathetic chain, because we've already discussed these two are the most important locations for the neuroblastoma tumors. While along the sympathetic chain, the most common locations are paravertebral region of the abdomen in 25% of the cases, and posterior mediastinum location is actually in 50% of the cases. While these tumors may also rise in pelvis, neck, and within the brain. And obviously, if they are present within the brain, they are called cerebral neuroblastomas. About the size, the size actually range from minute nodules, which are called in situ lesions. And if you don't know what exactly are in situ lesions or carcinoma, well, pause again and go and Google it. Thank you. Well, yeah, so their size can actually range from minute nodules to large masses which are more than 1 kg in weight. Okay. Now, let us discuss some of the specific points of the in situ neuroblastoma. Okay, for the in situ neuroblastomas are actually 40 times more frequent than your large tumors. Okay, and these in situ neuroblastomas usually spontaneously regress, and in them they may sharply be demarcated. They may sharply be demarcated by the capsule, which is obviously the fibrous pseudocapsule, or they may invade the surrounding structures that include the kidneys, renal vein, vena cava, and envelope aorta. Now let us talk about some of the histological features here. Okay, histologically you would find small primitive appearing cells. Okay, and they have very dark nuclei because obviously a large amount of nucleus material is present. Very scant cytoplasm. That's why you're actually seeing these blue colored small cells, and that's why it's a little bit harder to differentiate them from those small round blue cell tumors. Okay, because they are also small round blue cells. But very important to note is that they have the rosette appearance. We're going to discuss it, but I'm telling you here that the rosette appearance here, okay, yeah, the rosette appearance is why it's called rosette appearance, because obviously it in histological grounds it gives the shape of the rose. You can see here the cells or the nuclei or the cells that are actually coalesced together. Okay, and in the middle you can see this fibril material. Okay, and you can see that they look like a kind of paddles. You know, they look like paddles, and yeah, they do kind of look like rose, do they? I think I'm wasting a lot of time on that, but yeah, that's actually the rosette appearance. And what else? And the poorly defined cells, they have poorly defined cell borders that are growing in solid sheets. You would see the mitotic activity, you would see nuclear breakdown, karyorrhexia, which is called, you would see pleomorphism, and you would see faintly eosinophilic fibrillar material, which is called neuropil, and that corresponds to neurotic processes of the primitive neuroblast. And you would also see the rosettes, which I already told you what they are. They are also called Homer-Wright pseudo-rosettes, and they can be found in which the tumor cells are concentrically arranged. You see, they were concentrically arranged. Now let us discuss about ganglioneuroblastoma. The ganglioneuroblastoma are actually larger cells having more abundant cytoplasm than that were present in the neuroblastoma. They have large vesicular nuclei, and they have prominent nucleolus representing ganglion. Okay, so those large cells, large vesicular nuclei, and those prominent nucleolus actually represent the ganglion cells. And because you would also find small amount of primitive neuroblasts as well, so that's why it's called ganglioneuroblastoma. So this is the second type of neuroblastic tumor that we have discussed here. Another is ganglioneuroma. Well, here you would also find large cells that also resemble the mature ganglion cells, just like in ganglioneuroblastoma, but they have very few, almost nil neuroblasts. That's why they're specifically called ganglioneuroma, not ganglioneuroblastoma. Okay. Actually, very important is that the maturation of neuroblasts into ganglion cells is actually accompanied by the appearance of Schwann cells. So in ganglioneuroma and ganglioneuroblastoma, you will find Schwannian stroma. Okay, and this is a very important diagnostic histopathological feature that you would see. And that's Schwannian stroma actually composed of organized vesicles of neuritic processes, mature Schwann cells, and fibroblasts. Because in order to convert from neuroblasts to ganglion cells, it's actually accompanied by the appearance of Schwann cells. Okay, so and you would also see in Schwannian stroma the fibroblasts. Now, at least 50% or more Schwannian stroma is actually required before the particular neoplasm or the histopathological slide can actually be classified as either ganglioneuroblastoma or ganglioneuroma. So ganglion cells alone are not enough to actually classify that slide as either ganglioneuroma and ganglioneuroblastoma, but the presence of Schwann cells, or not just Schwann cells, but at least 50% or more of the Schwannian stroma, Schwann cells is actually required for the clinical significance of ganglioneuroblastoma or ganglioneuroma. Thank you.